Good day, and welcome to the open briefing for delegates to the World Health Assembly, held online this year at the Global Health Center of the Graduate Institute for International Development Studies in Geneva. My name is Vin Kim Nguyen, and I alongside Suri Moon, who will be chairing the second half of our webinar today. Although based in Geneva, I'm speaking to you today from Montreal North, which is the epicenter of Canada's COVID epidemic, where I'm currently working as a physician, hence the get up. I should say it's been a great pleasure to work with Ambassador John Lang at the UN Foundation team to organize this event. These extraordinary times mean that this 73rd World Health Assembly, as well as our briefing, will be the first ever to convene online. This briefing today will introduce how this unprecedented assembly will work and will be followed by an update on the COVID response from the WHO. A diverse panel of experts will explore key issues emerging in the global response to the pandemic, including resource mobilization and financing, human rights and gender equality, and international cooperation for innovation and access to health technologies. We will, of course, be making time for Q&A from the audience, but do please note that this discussion will be videoed and shared online after the event. Briefly, a few words about the Global Health Center, which serves as a hub for research, teaching, and convening in Geneva. Many of you know that Professor Lona Kickbush founded the center 10 years ago and led it until last September when Suri and I came on as co-directors. Ilona continues her involvement at the center as both a researcher and as chair of our International Advisory Board. At the center, we are interested in issues of global health governance, diplomacy, politics, and power. We strive to open global health to diverse perspectives and voices, building on a broad range of projects that include innovation and access to medicines, the role and potential of digital transformations, particularly for youth, sexual and reproductive health, and of course, the governance of outbreaks. Please visit our website where you can find out more. And now let me hand the floor to Ambassador Elizabeth Cousins, who is President and CEO of our partner here, the UN Foundation. Over to you, Elizabeth.
Thank you so much, Vin Kim, and it's a real honor to join you in welcoming everyone to the 6th Annual Open Briefing on the World Health Assembly. Let me also thank everyone at the Global Health Center for co-hosting this briefing with the UN Foundation. We value your partnership enormously, and I hope that next year, the Global Health Center and UNF will be able to welcome everyone to the auditorium at the Graduate Institute for a traditional in-person meeting just before the assembly begins. You know, this is a critical time, as we all know, and we need global solidarity more than ever as the world copes with the COVID-19 pandemic. WHO, under Dr. Tedros's leadership and with his incredible team, has been at the center of the response, and we are very pleased that today we will hear from WHO leadership to discuss their work. There are, of course, many issues related to WHO's COVID-19 response, ranging from changes in the very procedures of the World Health Assembly, to financing requirements, to gender and human rights, access to medicines, and many more. And leading experts are with us today to discuss these issues. Finally, I would just like to express the appreciation of everyone at the UN Foundation for the privilege of working in such close partnership with WHO, together with the Swiss Philanthropy Foundation in hosting the COVID-19 Solidarity Response Fund that many of you may know about. This is a way to channel flexible funding from non-traditional donors to the global response and consistent with WHO's Strategic Preparedness and Response Plan. There has been an overwhelming response since we started the fund 2 months ago from nearly 400,000 individuals, companies, foundations, and organizations who've pledged over $200 million thus far. The funds have come fast, which, as you all know, is a critical component. They've been generous, which has been essential, and they've come from all corners of the globe, which I think tells us something truly important about people's widespread commitment to working together to tackle this challenge. So I thank you all for being here. You are very much part of that story, all of you. And I'm delighted now to turn the floor to Ambassador John Lang. Ambassador Lang is Senior Fellow in Global Health Diplomacy at the UN Foundation. He's been a pioneer in the field of global health diplomacy, and among his numerous positions, he was the US State Department's Special Representative on Avian and Pandemic Influenza. I encourage you to check out his full bio in your materials, but now, John, over to you.
Thank you very much, Elizabeth. it's really a privilege for me to be part of this WHA briefing for the 6th straight year. The rules and procedures for this year's assembly are like no other. And we're really fortunate to have with us today Professor Gianluca Bersi of the Graduate Institute to explain them. Gianluca served in the WHO legal office beginning in 1998, and he was actually the legal counsel for WHO from 2005 to 2016. He's the co-editor of the Research Handbook on Global Health Law and is one of the world's foremost experts on the subject. Gianluca?
Thank you, John. And it's a privilege to be back for the 6th time in a row at this WHA briefing at very exceptional times. So I will try in 10 minutes to give some ideas, at least to clarify to the extent I can, how not only the Health Assembly, but also the Executive Board will meet next year. As you know, COVID-19 has had a tremendous effect on the governance of the United Nations system. Even the Security Council is working remotely. The International Labour Conference will not even meet this year. So, but obviously the World Health Organization in a way has to meet, to launch and to send a strong signal on COVID-19 and to perform other essential institutional duties. That is why the Secretariat of Member States have been working on a number of exceptional procedures that I will try to summarize. Before doing that, I would like to make a little disclaimer that there is relatively little information on the public website. So what I'm going to tell you is what I've heard from colleagues in the Secretariat or from some delegations in Geneva. So in a way, they're second-hand information, and I cannot vouch 100% for the accuracy, and understand that some details are still in process. So please take what I'm going to tell you with a grain of salt. At least I give to you what was given to me. So the exceptional procedures are articulated on 4 points. The first point concerns the session. The WHA will have a virtual session completely online next Monday, 18th of May, with a possible continuation on Tuesday the 19th if need be. After this virtual session, the Assembly will not close, but will suspend, will adjourn, with the intention of resuming the session later in the year, COVID allowing, of course, for a full physical session that we consider the rest of the agenda. So if things go according to plan, the session will be articulated in 2 times, virtual next year and physical towards the end of the year. The dates for the resume session will be decided by the Executive Board that has that authority under the Constitution. The second point is the agenda. If you go to the WHO webpage on the Health Assembly, you will see that there are 2 agendas. One is a provisional agenda, which is a usual list of items that is discussed in normal times. The second is called an abridged agenda. On Monday, the proposal by the Secretariat, which by the way, are only proposal that will have to be formally approved by the Assembly first thing on Monday morning, will be for the Assembly to adopt the 2 agendas, the full and the abridged, but with the agreement that next week only the items on the abridged agenda will be decided and will be discussed. And the other items will be discussed later in the year when the Assembly will resume in a normal meeting. What are these items? 2 orders of items. The first are items that are necessary from a constitutional and institutional point of view. And these are the election of the officers. You need a president and 5 vice presidents, and the election of the members of the Executive Board. That's essential because the board has emergency functions under the Constitution. And should the board have to meet in the next few months, and 1/3 of its membership were missing, there would be a big and legitimate question on its authority, to be very impossible to meet. So it's essential to elect the members of the Executive Board. The second will be obviously COVID related. And there is an item on the address by the Director General under which I understand the member states will consider the draft resolution that was tabled by the member states of the European Union some weeks ago, and that is very close to be agreed upon in consultation with other member states, or has even already been agreed upon. These I really don't know. So there will be, address from the Director General, the resolution on COVID, and I understand that there will be one or two invited speakers, senior leaders, that will deliver their messages on the fight against COVID-19. The third point is a very methodology. How will the assembly work? First of all, it will meet only in plenary. There will be no committees, no committee A, no committee B, no general committee. Member states and other participants can make statements in written form that will be loaded on the website, or orally by signify their intention to speak. Non-state actors will only be able to hear, will not be able to speak, but they can post the statements online. The work will be largely done by consensus, and I know that this is essential because voting online with 194 member states scattered around the world is a tremendous challenge. But I understand that there is a contingency in case of a need for a vote. The vote will be done by a roll call, where the Secretariat will call members one by one, and they will say yes, no, or abstention. But that can take a long time, and there can obviously be a challenge because of connectivity problems and so on. The members of the Executive Board will be elected by consensus as proposed by the 6 regions of WHO, and that's more or less the practice in normal times. The fourth point is what the Secretariat proposes in terms of other resolutions. The Secretariat proposes that after the adjournment of the virtual session next week, it will communicate to member states a list of decisions and resolutions that are potentially uncontroversial. I'm not sure what they are, but maybe those recommended by the Executive Board. And we'll ask member states to basically adopt them tacitly, given a certain deadline. If no member state says anything by the deadline, the resolution or decision will be considered as validly adopted. And that's it. There will be no consideration, no further consideration at the resume session. If one or more member states object, then the draft decision or resolution will be submitted to the resume session. So as you can see, these are really special procedures to try to transact as much business as possible, given the constraints imposed by COVID-19. And similar arrangements will be used for the Executive Board that will meet on the 22nd of May, again with a very skeletal agenda for institutional purposes, to elect the officers and to elect the members of a number of subsidiary bodies that must meet throughout the year and that need to be elected. The membership needs to be renewed. So I will not say much more. What I said for the Assembly largely applies to the board. I want to conclude by noting something that many people in Geneva already know, and that's a potential complication, and that is that 13 member states have asked for the inclusion of an additional item on the agenda of this Assembly. And the item has to do with inviting Taiwan to attend the Health Assembly as an observer. It is not the first time that it happens. I think it's the 13th or 14th time that it happens. In the past, it was always dealt with a sort of a practical arrangement that had become rather sort of repetitious. So the country agreed to do that. And that is to say that there were 2 statements in favor, 2 statements against the proposal, and that the Assembly agreed to reject it, not to consider it, by consensus, without a vote. So I understand the consultations are in process to try to agree on a similar arrangement. But if there is no arrangement and there has to be a vote, we go back to what I said before. It would be a vote by roll call, and it obviously could take a long time and could be a bit disruptive. So this is what I know, and at least I hope I gave some clarity, at least on the basics of what you can expect next week. It will be WebExed, so the public can fully listen in. Many thanks, and over to you, John.
Thank you very much, Gianluca. That's very helpful for all of us to know, because this is really such a special time and a much different WHA than we are familiar with. Let me now introduce our next speaker, who is Jane Ellison. And Jane has been a member of the Director General's leadership team since it was first announced in October 2017. She is the Executive Director for External Relations and Governance at WHO. And as many of you know, she came to WHO from the United Kingdom, where she had more than 30 years of experience in politics, commerce, and change management in both the public and private sectors, including as a member of Parliament and as Public Health Minister during the 2014 to 2015 Ebola outbreak in West Africa. Jane?
Thank you very much indeed, John, and thank you very much to all colleagues for inviting me to be part of this important briefing ahead of what will be a truly unique World Health Assembly. You've got some excellent speakers lined up during the session, and you've asked me to talk, I think, about particularly WHO's response to the COVID-19 pandemic, given this is the focus of this first virtual WHA. So I'm going to try and give you an overview in the time available to me about what we're doing to spearhead the global response. I mean, let's start with some sobering statistics. There are over 4.1 million confirmed cases of COVID-19 globally, and sadly over 287,000 deaths. So with COVID-19, WHO's mission resonates more than ever, and we're now trying to put that mission very much into action, promoting health, keeping the world safe, and serving the vulnerable. So on the 30th of January, WHO declared a FAIC, Public Health Emergency of International Concern, and 4 days after declaring a FAIC, we issued our first strategic preparedness and response plan, which had three key elements: the need for global and regional leadership and coordination, supporting country-level planning and countries to put together their own national action plans, and then coordinating and convening in the field of research and development. Ahead of the World Health Assembly, I'm going to focus principally perhaps on the global and regional leadership and coordination piece, but say a bit about the other two. WHO is actually leading the UN Crisis Management Team for COVID-19, which has 22 UN entities on it and 16 activity work streams. And clearly WHO's strong public voice based on science and evidence is never more needed than now. But we've also been challenged to find a new way to translate science and manage what we've called the infodemic of misinformation, of this enormous health emergency happening in a time, obviously, of a very different world of social media and all these other challenges that perhaps the last time the world faced a similar scale of challenge we didn't have. So the infodemic has been a big focus of what we've tried to do. We've also focused very much on trying to engage the whole of society. COVID-19 affects everyone. So WHO is engaging with individuals, communities, countries, health organizations clearly, but also travel and trade, employers, workers, food and agricultural sectors, and faith-based organizations. Everyone has a role to play, and particularly in promoting health by helping to get across the right guidance and sort of factual information. We've produced over 130 risk communication products, a mixture of myth busters, videos, posters, science packs in a range of languages, and we've never translated as much information as quickly as we have in the last few months, because we really want to try and make sure information is getting out there in ways that can make it very useful very quickly. We've been amplifying the message through webinars, over 60 so far, with 10,000 participants, and given sector-specific advice for many, many different parts of the global economy, which has been obviously hit so hard. We've also been drawing on some of the work that we'd already been doing. You've heard the DG's mantra time and again that the world should invest in preparedness, not panic. And WHO has been investing in preparedness, and some of that work has really come into its own in the last few months. If I give two examples, one is the open.who platform. We've delivered over 55 different resources and courses in 18 languages, with over 1.7 million enrollments so far delivering on this open training platform, and it's reached 190 countries. Another example is that's been operating actually since the 50s is WHO's Global Influenza Surveillance and Response System, that's got over 150 national public health laboratories in 125 countries. This has been really important in terms of establishing the network of testing for COVID-19 And in fact, 80% of those national labs are associated with the GISRS, or who are testing for COVID-19. This unique function that we found ourselves in terms of driving data and technical guidance has also been incredibly important, and making sure that we've been sharing in a timely manner key bits of health information. There have been 75 postings on the EIS system, over 100 global situation reports, with more from regional platforms, a real-time online data dashboard. 5 times weekly, we're issuing epidemiological record, WER, articles about COVID-19. And of course, as many of you will have seen, extremely regular Director General-led press briefings and weekly member state briefings, latterly hearing from member states themselves from right across the globe on how they've been responding to the outbreak and to the pandemic in their countries, allowing member states to actually hear each other and learn from each other. That role of leading the policy and technical guidance has obviously been absolutely critical. Steering policy has meant a lot of convening in recent months. So, for example, you know, at HQ and regional level, convening over 73 meetings of different leaders, 11 meetings of global health leaders to advise the Director General directly to make sure we have a true diversity of expertise and voices. There've been 18 STAG IH meetings, and clearly we're bringing together experts all the time to develop guidance. One of the questions you often hear journalists asking in press conferences, why hasn't this happened, or what do you know about this? And you often hear scientists saying, this is a new virus. Everything we know about it, we've discovered in the last few months. And this is, I think, something the world has had to adjust to. And it means that we're issuing technical documents all the time and having to convene experts to bring together what we know. So over 95 technical documents have been published by WHO, including over 50 guidance documents so far, covering areas like clinical management, laboratory science, supply and logistics, modeling, and infection prevention and control, obviously. So what about the country level impact and supporting the national response planning? You know, this is every single country is having to respond to this enormous challenge. And so WHO's 147 country offices and 6 regional offices have been highly mobilized. Let me give perhaps 2 examples of where we've been providing support at country level. One of the very first things we needed to do was to scale up the COVID-19 testing capacity, and particularly we focused on scaling up that capacity in the African region. In February alone, there was a 16-fold gain in terms of the number of countries that had testing capacity. And by mid-April, 94% of countries in the African region have got PCR testing capacity, including 4 countries that got their first ever PCR machines. WHO's role in doing that was technical support, missions, some of them virtual because it's been very difficult to move people and goods around, supplying equipment and facilitating those test kits. And all of that has had to be funded as well. Another area where we've been really, I think, making a big difference with country impact is helping countries with essential supply needs. As at the 1st of May, WHO provided critical items of PPE to 106 countries, including over 3 million respirators and masks, 1.8 million gloves, pairs of gloves, 187,000 gowns, over 30,000 goggles, over 80,000 face shields. But these numbers are far less than is actually needed. We've shipped diagnostic kits to 127 countries, enabling over 1.1 million tests to be conducted. But when we updated the Strategic Preparedness and Response Plan in April, and last week updated the resource needs attached to that, one of the big features that we sought to address was how some of these important global platforms and global goods could be really stepped up to address the scale of the challenge facing us. And the area around supply chain and supplies is one of them. At the request of the UN Secretary General and our own Director General, and in support of the UN crisis team, a unique supply chain task force has been convened to establish the COVID-19 supply chain system, which brings together a large number of UN agencies to really try to tackle this huge challenge of the end-to-end supply chain for critical supplies. We all know that that there is a very, very competitive market out there for many of these supplies, and many of the world's poorest countries and most vulnerable people would otherwise, without significant action on our part, struggle to get the supplies that they need. And we're determined to try and tackle that with this unique UN supply chain action. Another area in which we've been providing country support is through facilitating surge support into countries, and obviously technical support. It's been more difficult with all the lockdowns, but despite that, we've coordinated the response of 249 partners and technical networks based in 77 countries. Some of that's been virtual support, but we have actually managed to mount missions to 97 countries. We've also been coordinating the network of through our weekly EMT network calls, engaging 120 experts, and that means we've deployed 19 emergency medical teams internationally, 500 national teams have been mobilized, and over 3,000 frontline responders trained. So, you know, it's been difficult, undoubtedly, but nevertheless, many of those key elements of WHO practical support to countries we've been able to supply. And we've also, like many of us, had to reinvent the way that we do things. And some of it, I think, will stand us in good stead for beyond this immediate COVID-19 pandemic crisis. Lastly, just a word on the global research roadmap, which we've been coordinating. In 2016, the World Health Assembly supported a global strategy for rapidly activating R&D activities during epidemics. And much of that was based on learning from the West African Ebola outbreak. And that we regard as a global good. And building on that, in early February, WHO convened scientists from around the world in a joint effort to accelerate research. That's led, amongst other things, to the Solidarity Trial launched by WHO and partners, now with over 90 countries engaged and over 1,600 patients enrolled. And there is many more, there is a lot more happening, obviously, in that critical space, and one in which WHO is extremely active. Apart from some of all these challenges, one of the other challenges is, well, two, I suppose, big ones to mention before I close. One is around coordination. I think many member states and contributors and partners are trying to understand how all the various initiatives, both of the UN and national plans, come together. And WHO is working really closely with our colleagues to try and make sure that what we do makes sense in that context. For example, how the global humanitarian response plan comes together with our own strategic preparedness and response plan to make sure that we present that coherent message to the world. And we also have to mobilize the resources to do all this. When we updated our plan, we identified that for 2020, WHO needed $1.7 billion US. We've already received $580 million US, and there is more in the pipeline. But this is obviously a significant ask, but that encompasses what we've identified as the WHO needs as part of both the Secretary General's socioeconomic plan, the health first pillar of that, but also the global preparedness, humanitarian preparedness plan. And it really, I guess, the mention of that brings us back to the sort of first principles, which is WHO's mission, promoting health, keeping the world safe and serving the vulnerable. And it never been more, I think, needed than it is today. We would like to very much thank all member states, all our partners, and UNF has been a fabulous partner, as Elizabeth said in her introduction, in this very exciting initiative of the Solidarity Response Fund in recent months. But thanks to all member states, partners and contributors for the huge support that we've received. We remain absolutely committed to that mission, and we look forward to the virtual World Health Assembly and the chance to show at this time of extraordinary international challenge, true global solidarity as we tackle together COVID-19. Thank you.
Thanks very much, Jane. That's an impressive overview of all of the actions that WHO has taken and the challenges that you face. At this point, we're going to hold a roundtable discussion on some of the key issues related to pandemic response, moderated by Swery Moon. Now, Swery, many of you know, is the co-director with Vin Kim of the Global Health Center and a lecturer at both the Graduate Institute and the Harvard University T.H. Chan School of Public Health. Prior to joining the Graduate Institute, she was study director of the Harvard London School of Hygiene and Tropical Medicine Independent Panel on the Global Response to Ebola. Swery?
Thanks so much for the kind introduction, John. My name is Swery Moon, as you've just heard. And really a great pleasure and honor to be with all of you today. I'll be your guide for this second part of our program. I just wanted to start with a couple observations about some of the context within which we find ourselves. Clearly, this is an unprecedented WHA, and that's very clear. What is not yet clear is who will have an advantage as a result of these new arrangements and who will be disadvantaged. I think this is something that remains to be seen. This is an unprecedented moment for WHO. It's in the public eye as it has never been before. It's also under fire in a way that perhaps it has never been before. We see that WHO is walking a tightrope in the middle of a storm between two major world powers. Looking beyond WHA and WHO, this is of course also a time in the year when the global health community has traditionally come together to debate some of the key and pressing issues on the public agenda. Our speakers, whom you can see on the slide in front of you, are here to help us kick off that debate this year. Some of the themes that they will be covering include international cooperation, which has unfortunately been in somewhat short supply, I would say, over the last few months. We know that epidemics are a stress test on all countries and also on relations between countries. They can widen the divisions and the disparities that we already see, whether that has to do with gender, whether that has to do with class, technological capacity, or any other disparities that we see within and across societies. This is also a stress test for us, for the global health community, for the global health system at large, which of course includes WHO, but also the many small and large global health initiatives that have been built up over the last few decades. And this includes many of you who are joining us from around the world today. Last but not least, I think it's clear that this is a moment to think beyond business as usual, to move beyond politics as usual, and the WHA will be a test to see if that is in fact possible. I see that a few of you have already begun to put your questions into the Q&A, so please continue to do so. We'll have each of our speakers present their reflections in turn, and at the end we'll open up the floor for Q&A with the audience and also together with some of our speakers from the earlier panel. The one exception to this is Ambassador Stephanie Seydoux, who will be our first speaker. She's the ambassador for global health from France. She serves on the board of UNITAID and the Global Fund, among many other roles. And because she is temporarily stepping out of the Global Fund board meeting, we'll allow time for at least one question from the floor to her after she wraps up her remarks. She has worked across the French government for a number of years to combat discrimination and to promote the rights of women and gender equality. So Ambassador Seydoux, welcome, and thank you so much for taking time out to join us today. I just want to make sure that we can hear you and that you can hear us.
I think I can hear you really well. I hope you can hear me.
Wonderful. Yes, perfect. Wonderful. So let's dive right in. Just about 10 days ago, a number of countries mobilized 7.4 billion euros. And first, I really want to congratulate you and the government of France, which played a leadership role among a number of other European countries in spearheading this effort. And I think that prior to this pledging conference, it's fair to say that a number of countries seem to be demonstrating inward-looking attitude, let's say putting short-term national interests ahead of longer-term global interests. Do you think we've turned a corner? Do you expect to see more international cooperation in the days to come? Over to you.
Thank you very much, and thank you for a great question. Very glad, by the way, to be amongst you, and I'm very honored to be given the floor on this great occasion. My answer will be twofold. I think we are seeing possibly the best in multilateral cooperation, but I'm not saying we're going to see the worst, but I'm saying there are quite a few points of attention that we have to bear in mind. So, as seen from the point of view of France and the French government, there has been rather exceptional mobilization at leadership level worldwide. I think it's fair to say that. Only a few days after it became obvious that we were facing an unprecedented crisis, and I think it's fair to say that this has dawned upon most of us as something which was quite a shock and a surprise. And from the beginning, the G7 gathered and decided to take action and called on to the G20, which of course counts amongst its member many G7 countries, to do the same. And that happened before the end of March. An extraordinary G20 summit called for coordinated effort and solidarity in the response to COVID. This has been followed and accompanied by many calls by world leaders such as the Secretary General of the United Nations and many others, and naturally the WHO. And I'm very glad to be speaking after Jane Ellison, who very aptly reminded us all of how the WHO has really risen to the challenge to take action. France joined many African leaders and other European leaders in calling for specific action for Africa. And can I just stop on that call to say that this was an opportunity? Of course, other regions deserve attention. This was an African initiative which Europeans were pleased to join. This call was able to really point at the different and many complementary dimensions of the crisis: a health crisis, a financial crisis, a humanitarian crisis, and one which of course also calls for research to be a focus, including research from the South. So I think that was important. And then of course in this very positive mobilization, the event that you mentioned, the replenishment, as it were, or the call for pledges on May the 4th, which was led by the European Union, and which indeed was successful in raising $7.4 billion in order to advance COVID action, the Action for COVID Tools Accelerator. This was also an amazing show of mobilization and solidarity. So I think all of that is to be commended. And let me say that with others, France has indeed committed a significant amount of 1.2 billion.
Ambassador Seydoux, I think you've gone on mute for a moment. Let's see if we can get you back.
Oh, sorry.
Yeah, there we go. Okay. You were telling us about France's contribution, yes?
Yes, 1.2 billion to this effort. Now, this is definitely something which was never done before. I think it was never done before and never at that level. Points of attention, however. Well, the effort has to remain naturally sustained. One point that we in France are very careful about is what we call the eviction effect. We must be absolutely sure that whatever means are being addressed to COVID are not taken away from other actions, and that they are indeed additional. And this is true for health. So health systems must remain a priority, strengthening health systems, strengthening health policies, as you were saying. I've just come out of the Global Health Fund board meeting, and this is what this meeting is about. It's consolidating the core mission of the fund in a time of crisis, and certainly not stopping it or taking away means from its mission to fight COVID. And then, of course, there are other policies such as education, nutrition, etc. And the other point of attention is that of the vulnerability of populations and of rising inequalities in this time of crisis. Again, in the Global Fund, we know well how much attention has to be given to discriminated populations of all sorts. And there is obviously a particular attention to be given to the rights of women and young girls. And may I say that together with UN Women, France as a co-host is really looking forward to the Generation Equality Forum, which was due to take place in Paris in July, and which has been postponed to 2021, and which we consider, at least from the French point of view, as the moment when we will look back on how the crisis was dealt with from the onset, and how we all collectively ensured that the gender perspective was well taken into account. So this is what I would like to say at this stage in answer to your question, Suri. Thank you.
Thank you so much. And I think you've also raised a number of issues that I know some of our other speakers will be picking up on as well, particularly regarding inequality and certainly concerns around gender and the rights of women and girls. I wanted to come back to one point, though, that you raised. You mentioned challenges in making sure that some of these funds that are mobilized are additional. I think one of the immediate questions that came up after the euphoria of a very, very successful pledging conference was, well, actually, how is this money going to be spent? How is it going to be governed? Who will be at the table to make those decisions? Are we going to have adequate measures for transparency and accountability to address questions like additionality, as you just raised, but also many, many other questions that are coming up? There is enormous public attention right now, of course, to how this money will be used, a lot of interest. And indeed, this is a lot of public money being put on the table. So for you, what are the most important governing principles that need to be really carefully applied to make sure that these funds really have the effect that we hope they will have?
Well, thank you for a great question. This is ongoing. There's a lot of active work and proposals that are building up, and we hope soon stabilize into the good model, which which is being invented. France is a keen observer of what's going on as a champion of the process, also as a donor, but we're not amongst the first-line players in this. What principles? Well, the first thing that I would say from a French point of view is that what we're dealing with, well, apart from it being unprecedented, etc., and well, obliging us all to put our best brains and our best experience in order to move A, fast, and B, in a secure way, which does respect, as you say, accountability, transparency, and equity, is that this is about a public common good, which is, well, what is it? Is it health? Is it the product? Is it vaccines or treatments? Or is it the access to those products? Or is it the results of using those products? Well, all of that, I guess. Let's call it health for the response to COVID. All of that has to be considered from the point of view of a public common good. It will probably spur us into, indeed, being even more innovative in the approach to intellectual property and finding the right way to the right formula to encourage pooling, obviously in a discussion with all concerned, including private actors, naturally. To be followed. Other principles. So the principle, I guess, the overarching principle must be that of considering that this is exceptional and that what we're dealing with is a public common good. And then other principles such as, naturally, in the governance, inclusiveness. All countries must have a voice. Countries from the north, countries from the south. After all, we're all facing the same problem right now, which is to access sufficient quantities of the adequate tools to fight the epidemics and taking into account the state of our health systems. There needs to be representation of civil society, and it is a diverse, it's not a single concept, civil society, so in enough diversity, advocacy, development, humanitarian, probably for more wakes. Also the private sector, pharmaceuticals, industrial producers, etc. And what I believe is also would be nice is to ensure, not nice, but necessary, is a representation of communities. And this is not a token thing. Communities and community workers in particular are a guarantee that what is put in place will work, because they know from their very immediate experience on the ground, they have absolutely vital expertise on how we ensure that access is actually ensured all the way to the people that this initiative must serve. Now, maybe just very quickly, four other objectives of principles, I don't know, or at least points of attention which must be respected. As I said, I won't expand. An intention to health systems. This isn't only about finding a vaccine and then producing it. It's about deploying it and deploying it fairly. Scientific guidance. It's important that there is expert and independent advice given, maybe on a set of criteria, in order to decide what makes sense to go forward with, or to guide at least a decision. There needs to be a conflict of interest policy adjusted to this particular setup. And finally, there needs to be clear communication ensured by somebody. Now, on these last points, I believe that what we see emerging is a clear role for the WHO, who has certainly an umbrella part to play in this governance scheme. And I think with these are the different, I guess, principles and points of attention to be taken into account. It's not for me or even for my government to necessarily come up with the perfect plan. And I think we can trust everyone who's so keen to indeed make this work to finally get to the right setup. But at the end of it, what we must have is, in the allocation of funding, a mechanism that works. And let me say that for at least the very first stages, it's really there are already organizations which are involved in the core who do have their own governance mechanisms which can work perfectly well in the first instance. Maybe if there are indeed if there's new funding allocated to new objects, then obviously a dedicated mechanism would need to be found. And finally, there's need for fair, transparent, etc., and accountable mechanism for the allocation of commodities once they are produced. And from this angle, the platform which the WHO has set up, and which Jane Ellison mentioned earlier, is being put in place. It's a difficult task. It needs a lot of expertise, but from what we are hearing from our partners, this is coming up in the right way, and will require more effort, and will require obviously more expertise, but does look like the way to go.
Thank you so much. I think it's very clear that governance is not going to be one of the easiest problems to solve, but as you said, some of the most difficult issues do require legitimate, widely accepted governance, such as how we're going to allocate scarce commodities across and within countries. And I think you really made clear why it is that we do set up, even if it does take a bit of time, we draw lessons from previous global health experience, and we do set up governance mechanisms that everybody can buy into, because these are going to be very, very hard decisions. And I know that we have other speakers who will speak a bit more in detail about some of the issues that you've raised. I'm going to have to pull a bait and switch and actually ask the audience to hold. Please continue to put your questions into the Q&A box, but because we're running late, I'm going to hold the Q&A until the end of the session. I want to thank Ambassador Seydoux again for joining us in the middle of what I'm sure is a very busy schedule and in the middle of the Global Fund board meeting. Thank you so much. It's been a pleasure to have you with us. So let me introduce our next speaker, who is Dr. Gitara Gupta. She is the founder and executive director of the 3D program for girls and women at the UN Foundation. She is also a member of the Independent Oversight and Advisory Committee for WHO Health Emergencies, and the former Deputy Executive Director of UNICEF. If I were to summarize her bio in one line, though, I would say she has been a lifelong advocate for women and girls. So Dr. Gitara Gupta, let me just make sure that we can see you and hear you.
Yes, I can hear you.
Wonderful, there you are, great. So thank you so much for joining us. It's still early days here in the epidemic, but we can already guess that there are widespread social impacts, and these impacts are taking place, of course, in a context of severe gender inequality in many parts of the world. What are the impacts that you're seeing that are of greatest concern to you, whether that is across societies at large or looking inside the health workforce, where we know that women are, of course, the majority of the workforce that is right on the front lines? Do we even have enough information at this point to be able to understand what those impacts are?
Thank you so much, and thank you for inviting me to this forum, and greatest gratitude for focusing on this particular issue. There is some data that has come in that shows clearly that there are more men than women who are succumbing to COVID-19, but it is women who are carrying the socioeconomic burden of the pandemic. And that's what I'd like to talk about the most today, because those effects are threatening to reverse, stall at a minimum, but probably reverse some of the very slow, precious gains that we have made towards gender equality over the past couple of decades. There are really three categories that I'd like to talk about of gender-related impacts of the pandemic. The first is health consequences, the second is economic impacts, and the third are security concerns. All of these, I should say, have been summarized in a recent UN policy brief that talks about the gender-related impacts of COVID. Let's talk about the health consequences first. The most important are the health risks faced by women working in health services that you see a lot about in the media, and a lot of support for those women. Women are about 70% of the health workforce, but the majority of them, including nurses and community health workers, are in lower status, lower paying jobs at the front lines of this pandemic. And they are facing these health risks right there. And there are women also who occupy many of the support jobs in health services, cooking, serving food, cleaning, washing, and they are also at risk of exposure. Women are also disproportionately devastated by the diversion of resources within the health system to fighting this pandemic. So, for example, the attention and the diversion of resources to COVID has kept other essential health services and supply chains, they're no longer as operational as they used to be. So, for example, we're hearing from India that community health workers, the ASHA workers as they're called, who distribute contraceptives, provide maternal health care, distribute menstrual hygiene products, are now consumed with COVID-19 related services, as they should be, but making it very challenging for them then to provide any of these essential reproductive and sexual health services and supplies to girls and women. There's also a recent estimate from UNFPA that 47 million women from about 114 low and middle income countries may be unable to access modern contraceptives if the lockdown continues for 6 months. It's because there'd be great disruptions to health services. So lockdowns and the fear of exposure to the virus also threaten to reduce the number of facility-based deliveries. That's an indicator in maternal health that we had seen some progress on in the past decade. It's not yet clear what implications that will have for maternal mortality and morbidity, for fertility rates, particularly for adolescent pregnancies, and for HIV transmission. If we are to draw from the experience of Ebola, we know that the number of women who died in childbirth in West Africa increased by 70% when resources were diverted to Ebola response efforts. And let me then turn to the economic impacts. As you probably all know, women have long held the most precarious jobs and made less money than men, mostly in the informal sector. This novel coronavirus exacerbates those inequalities, those economic inequalities. And economists have pointed out that compared to regular recessions, which affect men's employment more severely than women's employment, the employment drop related to social distancing measures has a large impact on sectors with high female employment shares, particularly informal work. So approximately, just to give you a sense of how large the numbers are, there are 750 million women around the world who work in the informal economy. Or to put it another way, in developing economies, informal work makes up 70% of women's employment. So as domestic workers, waste pickers, farm workers, self-employed micro-entrepreneurs, women's incomes are critical for family well-being, and yet those are the jobs that are the first to disappear in such a crisis because of restrictions on mobility and public interactions. Informal workers the world over have very little bargaining power and are not covered by job-related benefits, which can be counted on in such times of crisis. So that makes them further vulnerable. And then there's the burden of unpaid care work that globally girls and women bear the burden of much more than men. It is estimated that girls and women on average do 3 times more unpaid care work than men. And that burden, as we all know well personally, has substantially increased because entire families are now home, schools are closed, and this leaves girls and women less time for education, for paid work, which also exacerbates existing inequalities. In fact, where we work through the 3D program in rural Maharashtra in India, we're increasingly hearing about girls dropping out of secondary school, out of college, and because of the increased burdens of household work, but also because of restrictions on mobility. And without education to occupy them, parents are now considering early marriage. So we are also worried about the age of marriage now dropping. Turning now to security consequences around the world, as you probably have seen in the media, there have been reports of spikes in rates of domestic violence and abuse of women and children as people are trapped indoors and women are trapped indoors with their abusers. Just to give you some data on this, reports of domestic violence in France, for example, have increased by 30% since the shutdown. In China, police reports show that domestic violence levels tripled during the outbreak. Similar increases have been reported by countries around the world as unemployment grows, frustration and anxiety grows. And the UN cautions that the violence against women is taking on a new complexity. Exposure to COVID-19 is being used as a threat, with abusers exploiting the inability of women to escape, of threatening them that they would be thrown out on the street with nowhere to go. In terms of data, you referred to the data that's available now, it is actually heartening to see growing attention being paid to this issue, and so growing efforts to gather data on this topic. Both on the way in which the virus is exacerbating already existing gender inequalities, but also on how existing gender-based inequalities are sort of exacerbating the social and economic consequences of this pandemic. I should say, even so far, have sufficient data to know that we need to respond more effectively. We have to find ways, though, to capture this data more systematically. I know Global Health 50/50 is tracking the sex-differentiated data across countries on morbidity and mortality, but we need to track indicators of gender equality, indicators for fertility, for child marriage, to see whether those indicators are going to move now because of this pandemic, especially higher education as well.
Indeed, even the results that we've already seen from some of the early research is sobering to say the least. I'm going to have to be very quick, but I just wanted to ask you one quick follow-up question, which is, we've seen now at least some of the beginnings of the impacts. To what extent have women been involved in decision-making? For example, how gender responsive have policies been to some of these concerns? And do you think this is an issue that will get adequate attention at the WHA in its truncated and virtual format this year?
I certainly hope some member states will raise this as an issue in the WHA, no matter how truncated this is, because it is very important. There are several recommendations to address these issues. you know, for healthcare to really keep the vulnerability of female frontline workers in mind, provide them with the necessary protective equipment, make sure that sexual and reproductive healthcare services remain as essential services and are prioritized like some governments have done. The Kenyan government has done that. Make sure that there are cash transfers for the most vulnerable families, particularly women-headed households, and that women in the informal sector get access to basic benefits and protections. We work with the Waste Pickers Union in India, for example, and they have set up a system whereby the daughters-in-law of the waste pickers are helping families get access to these benefits and sort of maneuver these complex bureaucratic systems in order to make sure they benefit. And we want, you know, improvements in security as well. We want to make sure that women are able to report incidents of violence, so hotlines are a good solution, but women often don't have cell phones. And so what are we going to do to make sure that they do? How do you repurpose existing facilities to serve as shelters is another possibility. I'll just say, because we're short of time, that I think most of this is more likely to happen if there were more women involved in leadership positions. Women in Global Health has called for increasing the number of women leaders in global health security in particular. And I think that's really important because their reality of the lived experience then will inform decision-making. We need that diversity and representation to have that happen. So I'm hoping that in this WHA, there will be some thought given to how these socioeconomic impacts could be better integrated with public health measures that are being taken. And I think that that's much more likely to happen if there is women's leadership, both at the senior level and at the grassroots, because the grassroots women leaders are the ones who will make sure that things get implemented and that there's a feedback loop to the leaders at the top on what the realities really are like. So let me stop there and say, I wish there had been greater representation of women at the beginning stages of this pandemic and that these socioeconomic impacts had been better integrated into the response. We've learned a lot from AIDS and Ebola of what a delay can cause. We certainly cannot delay any longer. So thank you.
Thank you so much. And I just wanted to flag that it sounds like there's a huge amount of room for improvement in making policies more gender responsive. We can only begin to touch on some of the issues here. I wanted to flag that we have an event next Friday co-sponsored with the Women in Global Health and Gendro, focusing on at least some of these issues for female health workers, certainly not covering all the issues that need to be addressed. Let me now turn to our next speaker, who is Chio Kling. She is the director of Third World Network, a lawyer by training. She has worked on health development and environmental issues since the 1980s. Third World Network is well known. It has worked for a number of years on access to medicines, intellectual property, pathogen and benefit sharing, all issues that are really coming to the fore again in the COVID-19 emergency. So Yokling, let me just make sure that we can see you and hear you. Yes, great, there you are. Wonderful. Thanks. Thank you so much for joining us. I know it's late in Kuala Lumpur, where you are right now. As you've already heard in some of the earlier comments, there's a lot of attention these days on access to medicines. We know that there are huge disparities between North and South. However, I think one of the big trends that we've seen over the last 10 or 20 years is, of course, the changing place of middle-income countries in the global order and the global economy. We have growing technological and economic capacity, development assistance, and some of the traditional Global Health 1.0 types of ways of working are no longer really addressing middle-income countries. So I think one of the key questions I'd like to pose to you and really dive into some of the questions that have already come up in Ambassador Seydu's remarks is, do you think a number of these measures that are being put in place will actually work for middle-income countries like Malaysia? Do you have confidence that this is going to meet the needs of the people that you see around you?
Thank you very much, Suri, and it's a pleasure to be on this panel. I first want to sort of raise the issue of what we understand by middle-income countries. You know, in the United Nations and in the WHO until recently, we had a very clear understanding of developed countries, developing countries. We also have very clear criteria for least developed countries, which really sets you know, the scene and the landscape for the rights and obligations. So when we talk about middle income, we are actually referring a lot to the IMF World Bank indicators. So you can have a country that has a lot of poverty, a lot of inequality, but because they may have certain, like oil, for example, as a commodity, that then raise their per capita income, or not per capita, total GDP to a certain level, then you get classified into a middle income category. So I just want to make that point because the term itself really does not reflect the level of development. So when we come back to the United Nations, I think one of the concerns that we've been having increasingly in Third World Network with all our colleagues around the world is that we have always pressed for universal healthcare. We have pressed for the importance of public health systems. And I think COVID-19 shows us how clearly the countries and even states within countries that have actually managed to actually control the transmission, flatten the curve and manage the crisis are the countries with public health systems still relatively intact and functioning, and that's very important. And part of that public health system really is about accessing affordable medicines, vaccines, diagnostics, through centralized procurement, through also promoting within the country's local production. So we have been seeing in the WHO across for many years now that universal healthcare in a world of really inequality means that we have to make sure that there is also equity in access, so that we don't have the race of the richest who can buy the most and the fastest in advance. So we therefore are very disturbed that right now, you know, the one substantive issue that's coming up for WHA next week is the resolution that the EU had initiated. And in the last weeks, the term universal, timely, and equitable access is so contentious because one big member state does not like the term equity. So I think Ambassador Seydu raised very important points just now, and so did Ms. Ellison from WHO. We are really, what is our basic global responsibility to the vulnerable, women, marginalized, vulnerable populations, and we're talking about the majority of the world here. And they are also within middle income countries, so-called, and even within the rich nations. We see the inequality laid bare in this pandemic. So we are really hoping that the WHA next week will at least have all member states stick to the principle of equity. The other concern we have is that all the past resolutions of the WHO have been very, very clear that we have flexibilities, very important rights, not just flexibilities, in the WTO Treaty on Intellectual Property Rights. The Doha Declaration affirmed all those rights in the balance between, you know, property recognition, innovation, and rewarding the inventors with very important public health interests and issues. So universal healthcare without equity cannot be a reality. So we have been very, very supportive in civil society for all the efforts of member states in the WHO that have actually put into place, you know, commissions of analysis, of inquiry, work programs on innovation, public health that recognizes that intellectual property as a private property model cannot dominate innovation and R&D for health. And so we have work programs which have been really slow because it's unfortunately frustrated, not so much by member states, but certain member states very strongly influenced by multinational corporations in the pharmaceutical sector. So across the board, from the United States to my country, Malaysia, to the poorest countries, to the most vulnerable, we now in today really have been crying out loud for governance around pharmaceutical industry. We see how the balance in intellectual property, particularly patents and medicines, have been completely out of balance. Really the rules that have been pressured, influenced, you know, at the national level, the norms that have actually pushed so-called intellectual property, especially patents, to be rewarding very little changes in medical products. One medicine has got multiple, even up to hundreds and thousands sometimes of patents around a particular medicine. So these barriers have been really the center, not just of civil society, but of member states who have gone to the WHO to fight for their right for public health, to try to bring balance back to intellectual property. So for us, equitable access and fair access means that we have to make sure that as many countries, as many of our companies in our countries can actually produce diagnostics and devices and medicines and vaccines. And we don't see that happening. And in the fight for equity, we find that the poorest countries, the most vulnerable, will get some degree of aid. The rich countries will actually have the money to go and buy. We saw that happening with masks recently, which was very, very, really unacceptable behavior. And we will see that with vaccines. And we see that with hydrochloroquine, maybe even remdesivir, if it works. We don't know whether this works, but if they work, there's a scramble. So I was very disturbed actually reading that the Sanofi CEO just yesterday, in an interview with Bloomberg News, actually said the US government has the right to the largest pre-order of whatever vaccine that could come out of Sanofi's work, because it has put money into Sanofi in a partnership. Now, this means that, and this really is a quote, right? That we have to, basically as a company, the Sanofi CEO says, we are manufacturing doses at risk. We don't know whether these vaccines will work. And we expect to get, whoever pays first will get the doses first. Now, this is not the principle of global cooperation. It's not the principle of leaving nobody behind. It's not the principle of equity. So I think this is really disturbing, and we would like to see this turn around. And WHO, member states within WHO need to actually put governance in place that will make us have equitable access.
Thank you so much. I think you covered a really broad range of topics. We're very, very short on time. I just wanted to ask you again one very quick follow-up question, which is, given all of the difficulties and the scramble already for drugs, for vaccines, what do you think concretely can make a difference? Because we have seen a number of governments and company heads actually saying very openly, we will serve our own populations first. We're going to hold that production. We're going to ban exports. I mean, this is something that has been happening in countries across the world, north, south, east, west. So what really can be done to address that? I think the rules are one thing. You talked about governance, but is there anything else that can be done to actually address that risk?
Yeah, I think the instinctive thing, and even my country, Malaysia, India, the first thing we did was with masks, for example. But we have 3 factories here that produce not N95, but 3-ply masks. And the first thing the government had to do, because we suddenly were not sure whether we had enough stocks for domestic needs, right? What happens if this thing goes out of control? And so the export restrictions came in. And actually that really tells us something very important, that basically the production, predominantly the production of all these health products are actually in the private sector. And so governments have no idea about supply, global chain, buffer stocks. And if you have a very privatized health system, you have even less buffer stock. And we found that in Malaysia, the public health system had much more stocks for, in the buffer than the private sector. And I think that's, you see across even the United States, is actually a good example of what happens when you don't have a good public health system. So the first reaction to put restrictions, I think, is understandable. But that is why we do need the global platform, and WHO is very important. As a Malaysian, every day our Director General of Health gives us a daily briefing, gives us facts, gives us figures, and inevitably, every briefing he talks about WHO. So the guidelines, what Ms. Ellison talked about, the protocols, the guidelines, the technical part, even the policy part, this has been really, for the South, whether we are middle income or least developed or developing, we have a lot of trust in the WHO. Right? The WHO has gone through a lot of crises and problems. We have heard that, and for very different reasons. But we cannot take away from the core of what WHO does, which is really that it's a hell of a lot of trust from the South. And we want a strengthened WHO. We don't expect WHO to go in there and make medicines, but they can actually coordinate. The governance we talk about has to be one where member states have to be involved, because ultimately the restrictions or the scrambling, that can be resolved if we have accountability of the states with civil society in there as well, to be able to sort of say, let's work this through together, right? And in emergencies, we need that more than ever.
Thank you so much. And again, we're just touching on a number of very difficult and complex issues. We will have another event next Thursday focusing particularly on transparency in pharmaceutical markets, which will give us time to go into a little bit more depth. I see that I am running very late, so I do apologize. I do want to make sure that we have enough time to address an extremely important issue. And so let me turn to my next speaker, who is Dr. Patrick Eba. He is the country director for UNAIDS based in the Central African Republic. He's a human rights lawyer by training, a professor of law at the University of Pretoria in South Africa, has been an expert serving on a number of advisory committees on health, HIV, and human rights, including the African Commission on Human and People's Rights. So let's make sure that we have you online, Dr. Eba.
Yes. Can you hear
me? Wonderful. Yes, I hear you very well. And let me just pause before I turn to you and let people know I have asked you to put your questions into the Q&A I think what we'll have to do is turn to posing those online, and we'll put them on Twitter. We'll ask our panelists and others to respond to those questions. So please do continue to share your thoughts with us, with each other. But I do want to make sure we have time to hear from Dr. Eba about some very significant concerns that have come up regarding violations of human rights. So let me first ask you, what have been some of the main human rights concerns and violations that you have already seen? We've seen, I think, an unprecedented intervention of government in day-to-day life around the world. We've also seen, for example, that transmission of the virus in some contexts has in fact been criminalized, that there have been abuses of individuals who have perhaps left their homes looking for work, looking for food, a number of really unintended consequences of public health measures. What is it that you're seeing, and what is the greatest concern to you?
Thank you very much, Suri. Really, I think this pandemic is about whether we've learned the lessons of the past, especially around human rights. And some 30 years ago, Jonathan Mann, the first director of WHO's Global Program on AIDS, warned us that how societies deal with pandemics and treat people affected with or vulnerable to diseases will not only test our fundamental values, but will likely make the difference between success and failure in our control strategies. This warning takes particular significance when we look at how governments are responding to COVID-19 today. In many places, our responses to COVID-19 are ignoring or even overtly violating our values and common commitments to dignity and human rights. For sure, human rights can be limited at time of pandemics, at least certain human rights. For those human rights that can be limited, including freedom of movement, privacy, and other rights, the limitations adopted by government must meet human rights yardstick of legality, proportionality, and reasonableness. Unfortunately, in many places, as you pointed, we are witnessing very disproportionate application of restrictions. COVID-19 laws in some countries are being used to justify abusive measures against civil society, political opponents, and sometimes against dissenting voices. HIV Justice Worldwide, which is a network of civil society organizations working against the overly broad use of the criminal law in the context of HIV and health, has documented across the world that the recourse of the criminal law is being used to target individuals who either allegedly fail to observe public health messages or do not report people who do not observe public health messages. We also saw very disturbing images and videos from a number of countries in which people were being beaten or subjected to ill treatment for not observing lockdown and other restrictive measures. In some circumstances, such violations may amount to torture or inhuman or degrading treatment, which, as we all know, torture and inhuman and degrading treatment are considered non-derogable rights, which means that under no condition can torture or degrading treatment be allowed or justified, not even on the ground of public health emergencies like COVID-19. I think we all need to realize that we will not beat, torture, or jail our way out of COVID-19 epidemic. The criminal law is only likely to lead to more human rights violation. It is only going to be counterproductive because it will drive people away from testing, which is actually the entry door to all the services that we provide from a public health perspective. We've seen this happening in HIV, and we should not let human rights violation take over our COVID-19 response. What is needed is really to empower people for them to come forward. We need to create trust, not fear. Another critical human rights issue in the context of COVID-19 is that of access to commodity for testing and treatment. And of course, Chi-Yok Ling just spoke about it in a very powerful way. But I want, if you will allow, to illustrate how this is so important to illustrate it with the situation of the Central African Republic, the country where I work. Here in the Central African Republic, we have less than 5 functioning respirators, an extremely limited capacity for intensive care. The country has less than 4,000 qualified healthcare workers for a population of more than 5 million. As we speak, we are left with less than 15,000 PCR test kits for COVID-19. In addition, this country is facing what is considered to be the 3rd worst humanitarian crisis in the world after Yemen and Syria, with half of the population in need of humanitarian assistance. Half of all people living with HIV in the country do not have access to treatment, which clearly makes them very vulnerable to the COVID-19 epidemic. Yet, in spite of recent progress in global solidarity, we are all witnessing a global scramble for masks, for tests, for other health products that ignore the needs of fragile populations, such as those of the Central African Republic. Let us all remember that in this global response, we are as strong as our weakest link. This is why we must all support recent initiatives, including the public letter uniting behind a public vaccine against COVID-19, which was launched today with the support of more than 140 signatories, including current and former global leaders, public health experts, and civil society leaders. But I want to end on this point by noting that at the end of the day, the human rights violations that we are noticing now were not born with COVID-19. They existed before. What COVID does is to magnify those violations. In countries with solid human rights protections and with strong human rights institutions and activism, they are able to resist and to fight back against attempts to curtail their rights, including in the form of tracking apps, etc. They are demanding transparency. However, in other places where freedom of speech is not guaranteed, where civil society faces oppressive laws, these violations go unchallenged. And often, it is at great cost to their safety and lives that some activists continue to challenge rights violation in the context of COVID-19. We have a responsibility to support these organizations and their work in the most challenging circumstances. We all have a responsibility to increase monitoring of human rights violations and to hold government accountable. And I really hope that as we prepare for this unprecedented virtual WHA, I really hope that the important issues of human rights will be on the agenda in all the COVID-19 related discussions, and that this will not turn into a blind spot of our conversation at the upcoming WHA.
Thank you so much. It's a really powerful way to come to the end of our webinar. I do think that it's not only WHO but the public health community at large. We have tended to focus on biomedical silver bullets. We have tended to focus on public health imperatives such as getting the virus under control. And I do wonder, Patrick, if you would just say one last word. How optimistic are you that these issues will get the attention that they need at the upcoming WHA?
You see, for me, really, the issue is less about whether these issues will be discussed. That's not the main question. The main question is really whether we will all have the courage during this WHA to take the important, the decisive commitment and actions to address the challenges, especially the challenges of human rights, the challenges of the socio-economic impact of this pandemic. And we have a number of tools, we have a number of frameworks to help us articulate these issues. You know, in 2008, WHO issued this groundbreaking report of the Commission on Social Determinants of Health, which lays out all the considerations around what we are facing today. The question is whether we have the courage to address them. And that leads me also to talk about the fact that during this WHA and beyond this WHA, we really need to talk more seriously about blanket and top-down enforcement of lockdowns without consideration of the socioeconomic conditions of people. I mean, at the end of the day, we are talking about privilege, we are talking about inequality, we are talking about fairness. We have to remember that affluent suburbia is not Kibera or Dharavi. That at the end of the day, these lockdowns are having serious impact on access to food, education, employment, women, and Rita spoke very powerfully about it. And these issues are those that we have a responsibility, the WHO has a responsibility to address, to come up with very concrete ways to moving forward. And I think that world leaders also have a responsibility to address some of those socioeconomic impacts. And I'm very grateful to France and to Ambassador Seydou and all the leaders who are actually putting forth those issues for addressing them. But we need to do more. We need to do more in the true spirit of global solidarity and cooperation. What we need is not less multilateralism, it is more multilateralism that is grounded in the spirit that we are one humanity and that we need to emerge out of this epidemic stronger.
Thank you so much, Dr. Eva. I could not even come close to ending our webinar on a more eloquent note. So let me thank you. Let me apologize to our participants that I've managed the time miserably, and I was really hoping we would have time for exchange. It's certainly one of the losses that we have when we do this virtually rather than in person, that we don't have a chance to follow up in person, face-to-face conversations with each other as we would. I want to go back and echo what Ambassador Cousin said at the beginning, which is that I hope that 1 year from now we can in fact meet all of you back in Geneva face-to-face, and that we'll be able to carry on some of these discussions. The world will certainly look very different then. Let me thank all of our speakers. Thank you so much for sharing your precious time and your reflections and wisdom with all of us. Let me thank our audience. Let me also thank our co-organizer, the UN Foundation, our media partner, Health Policy Watch. As you've heard me say a few times throughout the webinar, we have a number of events coming up. Today is really just the kickoff of WHA, not even week, but WHA 10 days, 15 days. And you can see on the screen and go to our website to see a number of upcoming events talking about the closing of space for civil society, the commercial and political determinants of health and how they shape the ongoing diabetes pandemic, transparency and its important role in trying to improve access to drugs, vaccines, and diagnostics, gender inequality, and last but not least, on May 27th, we'll be wrapping up with an event on how we can better build, in fact, stronger health systems, ensure that people have universal access to health and to health care, as a number of our speakers highlighted today, in a context of increasing concern about health security. Last but not least, I'd like to thank the staff of the Global Health Center and the UN Foundation. There are many, many people working tirelessly behind the scenes to pull together this event and the events to come. And last but not least, there's too many people to name, but one name that I would like to thank explicitly is Dr. Meg Davis, who has been leading our work to organize WHA Week on behalf of the Global Health Center. So thank you. Signing off from Geneva. I hope to see many of you virtually in the coming days and in person a year from now. Thank you very much.